Okay, so this is a pretty limited pelvic MRI. As you can see, there are only a few thumbnails across the top because the patient didn't tolerate the MRI very well, but it was a female to male trans patient who presented with vaginal bleeding and had an ultrasound that showed an unremarkable uterus and a multiloculated cystic right adnexal lesion. Unfortunately, I do not have the ultrasound because it was performed at an outside institution and didn't get uploaded to this particular PACS, but I have this MRI. And so I've got axial and sagittal T2-weighted images that I will scroll through for you. And I guess let me know if you're making any observations worth discussing.
That's a lot of cysts for an ovary.
Yes, exactly. And so there are also some additional cysts in this pelvis. Here, back here. You would wonder if this is separate from the multiloculated cystic mass here. And so we've got a multiloculated cystic right adnexal mass. Sort of curious if they're sort of encasing the ovarian parenchyma here, that's sort of, I don't know, almost smushed between the cysts, or if it's ovary sort of back here, and this is all just one sort of separate multiloculated cystic mass, and then the separate serosal and peritoneal cysts. Any thoughts?
Is this endosalpingiosis?
Yeah, so that's a great thought, and that's I've never prospectively called an endosalpingiosis, but I had read there are case reports of endosalpingiosis presenting as multiloculated cystic lesions,
then,
although
like,
that's very uncommon.
The way like they're like foci over the uterus, and I think there was one over the round ligament as well. I feel it's a good look for it. Yeah.
Yeah, exactly. And so all of these other ones are a great look for it, right?
Yeah.
And so I sort of said I was suspicious that there was endosalpingiosis and that this could also be endosalpingiosis, but commoner things being common for multicystic adnexal lesions, I suggested this could also just be like a serous cystadenoma or, other variant of epithelial ovarian neoplasm. And I have the final path, and this was a serous cystadenoma, and everything else was endosalpingiosis. So nice work.
Wow, that was awesome. Are they associated with each other at all? Like, is there a predilection to getting an epithelial neoplasm if you have endosalpingiosis?
Not that I read. I could not find anything to suggest that.
Can we see the endometrium again?
Oh yes, I was so focused on the other stuff. The endometrium is thickened. The images are limited by motion, but it's thickened, and I questioned whether or not it was cystic. And at hysterectomy, there was atypical hyperplasia.
Yeah, it looks really weird.
Yep, good observation. I also questioned whether or not there was a little bit of DIE at torus uterinus, but there was no mention of it on the path.
Awesome. Thank you. Maria?
Thank you.
All right, so this is a 79-year-old gentleman. He presented last night actually with abdominal pain and vomiting. And as you can see right off the bat, there's a lot of bowel in front of the liver. And then as you go down, there's a lot of edema within the mesentery. And that kind of, prompted me to look at the vessels. And I tried following the superior mesenteric. This is a portal vein. If you try following the superior mesenteric vein, it just kind of goes out. And then same thing kind of happens with the SMA. And as you follow it towards the right, it kind of becomes extremely narrowed and then tries to come back again. And then I was trying to follow like the normal relationships of the bowel. There's some small bowel loops in the right lower abdomen, which are not enhancing nicely. And then following the colon, I know it's hard. It took me a long time to follow the colon as well last night, but believe me that this is like the transverse colon coming up, and then the cecum is actually present in front of the liver. Let me show this on another, on the Saggy, and I think this will kind of show it a lot better what I'm trying to get at. So following the vessels, and there it is. And
It was a nice swirl.
yeah, but you see like this entity with like colon, like cecal or sigmoid. This turned out to be, can anybody guess what this is, just given the swirling of the mesenteric root there? So this is a small bowel volvulus, and he's not malrotated or anything. And the best you see is it's not very, you kind of get the idea that something's not anatomically correct and things are not in the right place on the axial, but you see that nice swirl of the mesenteric pedicle on the sagittal, and there's all this edema because of ischemia, because artery and vein both are getting compressed. And when they opened up this patient, they saw a lot of like whitish material in the mesentery. So there was lymphatic obstruction as well. So all this like kind of dense edema is combination of venous congestion and lymphatic congestion. And you can kind of see that the veins are like very poorly opacified. Apparently the cecum was kind of rotated up anterior to the liver, but it wasn't obstructed. So there's not much bowel obstruction compared to the degree of bowel ischemia. So this is like an example of a small bowel volvulus.
Very cool. I haven't seen that much edema, and I like that explanation about the lymphatics.
Yeah, and then this is like, I've never seen a small bowel volvulus. Like I've read about it and seen case examples, but this is like my first one. And he has no history of like prior surgery or anything, so I guess he's just old with lax ligaments. And that his.
I have a question. You know that cecum that's like above and compressing the liver? Like normally the cecum isn't that mobile. So do you think like maybe the mobile cecum was like the lead point for causing the volvulus?
It may have been, because the distal terminal ileum is also up there with the cecum. But the bowel that's getting ischemic and it's twisted is primarily the jejunum and the proximal to mid ileum, which is like all of it almost is like not enhancing at all. So I don't know, it may have contributed, but I feel like, you know, as people get older, their ligaments and mesentery, it becomes lax and just likes to twist.
Yeah, great case.
Yeah.
Were they able to save the bowel, by the way?
Oh yeah. They untwisted the bowel and it became pink again, and they didn't do any resection.
Nice.
Yeah.
Steve says wet ischemia transudate. Nice. Steve, welcome back. Do you have any cases?
Thank you. No, I mean, I'll look for some while we're going here, but I just feel happy to be here.
Awesome. Okay.
Okay. So I've got an ultrasound and an MRI to share with you. So let me scroll back up to the top. So in the liver, we have multiple echogenic masses. And if I could, this was sort of measured here as the echogenic mass, but when I get to the MRI, you'll see that this is actually part of a larger mass here that has a sort of slightly hypoechoic rim. And then there weren't a lot of great still images taken of other lesions, but as I scroll through this, cine, we've got labeled as right lobe. You'll notice all the shadowing up here, sort of segment 4A near the IVC very centrally, and some echogenic findings, sort of segment 7 back here. And so this was sort of read as multiple echogenic liver lesions, possibly hemangiomas, and an MRI was recommended. And so I'll sort of walk you through the findings because there are a lot of sequences and findings to go through. But even from the top, you can see that there are heterogeneous lesions in the liver, segment 7 over here, slash sort of border of 8. Some very low signal, but heterogeneous with some regions of very high signal as well. Same thing over here in segment 2. And where we saw especially all of that shadowing on the ultrasound, some more of that very low signal, but still overall very heterogeneous. And then here's that other lesion in the left lobe that I had shown you that had sort of an echogenic center or hyperechoic center and hypoechoic rim. All of these are very low on our fat saturated T1 pre-contrast images, and you can sort of see very low signal representing some susceptibility artifact where we saw all of that shadowing on the ultrasound. And I'll pull up some post-contrast images. Let me pull up some later posts. Maybe here. So we're misregistered a little bit as I scroll, but you can see that there's nothing really enhancing particularly avidly within these lesions, maybe a little bit of a rim here, enhancing somewhat avidly, but some heterogeneous hypo enhancement. Within this lesion, that central very marked T2 hyperintense region does enhance, so it's not cystic or necrotic, and it progressively sort of fills in and enhances, and as does the rim, this sort of thick rim. You'll notice there's also some capsular retraction associated with the lesions in the right lobe.
I'm wondering about EHE, given like the subcapsular nature and the kind of targetoid fibrotic nature.
Epithelial hemangioendothelioma, nice. Yeah, that is a really good thought. This lesion in particular, if you look up images of EHE, kind of looks somewhat typical of it, where you have a very hyperintense center and this targetoid appearance. Other ones, I think, less typical. I've read that they can calcify, but that's uncommon. And these are sort of more irregular and less targetoid. So that was one thing I thought about. I don't see anything that's like clearly a lollipop sign, but maybe if you trace some of these vessels, it leads up to the edge of it, and that's just where the blood vessel sort of runs into the EHE, and then I guess it sort of stops at the lesion, which sort of occludes and replaces that region. Any other thoughts?
Kedar said lesions have central calcification, some kind of metastases. So yeah, some colon cancer mets can calcify, like mucinous.
Yeah, so that was a thought too. She doesn't have any history of treated malignancy, and you know, I did think about that, but with the capsular retraction, I guess I've only seen capsular retraction associated with calcified metastases in the setting of like some sort of post-treatment state. And so I thought that was a little odd, but correct me if you have a different experience, please. And then I guess the only other sort of thing that I thought was, and then this would be very uncommon, could these be some sort of weird hyalinizing or sclerosed hemangiomas? Now, I've never seen multiple sclerosed or hyalinized hemangiomas in each liver, and these look atypical, but they are calcified. There is some capsular retraction. There are some regions of relatively high T2 signal within these lesions, particularly this one. And so I sort of had that on the differential as well. So I'm curious to see what you guys think of that. And also if you have any other thoughts, because that's sort of most of what I came up with for my differential and I recommended biopsy.
I like the hemangioma theory. And you can get hemangiomatosis. So I guess why not get sclerosing hemangiomatosis? Like multiple hemangiomas that are sclerosing, and they kind of like this one is at a different stage, so it's still in the sclerosing process, and the others are more sclerosed. So I like that theory. Yeah.
So unfortunately, I don't have the path follow-up on this one, but I will bring it back to you because I tend to stay on top of these things. So I will let you know. Any other thoughts out there before we move on?
Leaving us hanging. Okay, well, you have to bring the path back.
I will. Thank you.
Thanks. Okay, so this was a patient who had sort of shrunken down left lobe, biliary dilation. And you can see that the bile duct and also the pancreatic duct is a little dilated, and the bile duct actually inserts on this big thing that has an air fluid level. So this is a periampullary diverticulum, and it was inserting on it right there. So does anyone know what the syndrome is called, where you get biliary obstruction due to a diverticulum?
Like Lemmel syndrome. I may be wrong.
Yeah.
Okay.
Yeah, exactly. It's called Lemmel
There are
syndrome.
so many syndromes starting with L, like Lariche, Lemire, Lemmel.
Exactly. So this is Lemmel syndrome, and it's basically biliary obstruction due to a diverticulum, which can be just a air fluid, it can just be a fluid filled one, or sometimes there can be a bezoar in the diverticulum. And it's named after a German physician in 1934 who named it after himself, I guess, who was Lemmel. So it's kind of funny to me that like back then they'd like find something new and then just name it after themselves. But okay, I'm going to pull up my next case. Stop the recording. Steve says the mission of the next decade is to remove all the eponymous syndromes. I agree. Okay, this was an interesting case. This patient, this is a penile MRI for a patient who is experiencing Priapism. And you can see that the penis is very erect. Here it is on the high-res T2. And I'll show you on some post-contrast images. There was very poor enhancement of the cavernosa. The patient had been actually experiencing Priapism for like 3 days. And the urologist actually did something. I didn't know what this was, but they did something called a corpora glandular fistula. So basically, in order to relieve the Priapism, so like the blood is all stuck in the corpora, and it's going to cause ischemia, which we think basically in this case, there's probably ischemia because there's basically no enhancement here. So one of the techniques they do is to make an anastomosis, like basically open up the tunica so that the blood can drain just into the shaft, into the surrounding tissues. So they did that there and there, but it did not alleviate the Priapism. And basically they decided there was nothing else they could really do because if they went in to try to evacuate it, it can cause a lot of scarring. And so they basically said that there was nothing more they could do and that they would have to eventually do a penile implant. But the other interesting part of this case is that this patient has monkeypox and has been having the CD4 count is pretty low, and he's had monkeypox infection, and he had plaques on his penile shaft. So they actually thought that this could have been related to the monkeypox infection. So I just want to pull up something here. There was a recent study out of England about monkeypox, and they basically said that the recent outbreak has some new symptoms compared to prior outbreaks. And one of those new symptoms is penile swelling. So they didn't specifically say priapism, they said penile swelling. So I don't know if it's like subcutaneous edema, but one of the things they said is that in this study, there was 197 cases of monkeypox. This is the actual study here. And the 196 of them were patients who were gay, bisexual, or men who have sex with men. And a lot of them had mucocutaneous lesions in the genital area, perianal area. We've actually seen several cases of monkeypox proctitis, but that of the people who were admitted, 10% of them were admitted for rectal pain and penile swelling. So it's something we may see more of in our abdominal imaging, and just something to be aware of. If you see, proctitis or something going on with the penile shaft, think about monkeypox. Any comments? Okay, I'm gonna pause. Okay, so this was a patient who presented with an elevated bilirubin and elevated alkaline phosphatase. And this is what their biliary tree looks like. Kedar says PSC, excellent thought. So it looks like kind of beaded, irregular ducts. This patient did not have PSC, but it is something that can mimic PSC. I'm withholding a little bit of the history, but I'll just show you in the venous too. This patient actually has HIV and a CD4 count of around 80. So this was, we thought, AIDS cholangiopathy. So AIDS, patients with AIDS, usually if they have a CD4 count less than 125, they can develop cholangiopathy, basically infection, usually multi-organism infection in their biliary tree. The most common organisms are CMV, HSV, and cryposporidium. And the two main things that you see are a sort of PSC-like cholangitis, as well as papillary stenosis. So this patient did not have papillary stenosis, but they did have this kind of PSC-like cholangitis. So for me, this was my first case of AIDS cholangiopathy, where it looked really nice, like a PSC. And actually, this patient has had chronic diarrhea and just is tested positive for cryposporidium. So our theory is that this is maybe cryposporidium affecting the bile ducts. Maria says, beautiful case. And Steve says, splenomegaly could have been a hint. Yes.
I almost felt like this AIDS cholangiopathy mimicking PSC was an urban myth because I've never seen it in real life. I know it's always on the differential, and like I bring it up, but like when I'm teaching cases, but it's so nice to see that it actually.
I know. So reading the case, I was like, I don't know why they have biliary dilation. And then my resident says they have HIV. And I'm like, oh my gosh, is this finally a case? Because I only show them in like word reviews or read it.
Amazing.
This is my first case too. And his CD4 count was 84 and he has documented cryposporidium. So I was just like, wow, this is.
What a case.
Yeah. Okay, I have a couple more. Oops, go to a better sequence. Okay, so this is my next patient. Not an eye test. You can see that there's a large retroperitoneal mass and it's actually encasing the aorta. It's pretty solid and fatty. Any thoughts?
Can you show the left kidney?
Yeah, you need to show us the kidney and the adrenal gland a little bit better.
There's the kidney. It's being like pushed and the part of the hilum is kind of encased by the top of this mass. I don't see a claw sign. And the adrenal gland is right there.
I mean, it's a liposarc until proven otherwise.
Good. You fell for my trick. So I totally agree. If I had seen a big, huge retroperitoneal mass, liposarc until proven otherwise, I did give you a clue though, which is that I scrolled all the way down here and I kept scrolling.
Oh.
And something's missing here.
Yeah. So it's a metastatic germ cell.
Yes. So spermatic cord is gone. There's scarring from surgery. And this was a metastatic germ cell tumor. So I'm just going to pull up this Radiopedia page for a minute. So germ cell tumors. Germ cell tumors, 40% are going to be seminomas and 60% are going to be non-seminomatous germ cell tumors. This is the category that we're in today. These tend to be in younger patients. And a lot of these tumors end up being, kind of like some component of several of them. They're not always like pure. The most common is the yolk sac tumor that's seen more commonly in children. And those are the ones that will have the elevated AFP. And then my tumor was a combination of an embryonal cell, a yolk sac, and a teratoma. And the teratoma part here is the part that probably has this fatty component. So when you see a fat, large retroperitoneal mass, I mean, usually we're thinking liposarcoma, but you can also get a met from a teratoma or germ cell tumor. So don't forget about that. And this was a 30-year-old male. These non-seminomatous ones tend to be in slightly younger patients than the seminomas. The cool thing is that the patient's doing quite well. And hold on one sec. So the cool thing is they were able to resect that large tumor, and you saw it had been encasing the aorta, but they actually replaced the aorta. I didn't initially notice that the aorta was replaced here because it looked so beautiful, and I didn't see like a graft or a stent, but they did replace the aorta, and actually they have an aorto-fem bypass graft as well. So pretty cool. And I guess another clue would have been like, there's all these like clips here and stuff from all that resection. So, okay, I have one more case. Okay, one more comment about that last case. There is something called growing teratoma syndrome, and it's kind of an interesting thing. I think Nilly showed us a case of it before, but it's what happens when there's both mature and immature teratoma in your germ cell tumor, and the chemo is able to hit and shrink the immature part, but the mature part, because it's not a malignant lesion, doesn't get shrunken down by the chemo. So that part can keep growing because it's like the benign mature teratoma part. So if you've got treated testicular lymph nodes, but then like a fatty part is growing, that's what is called growing teratoma syndrome. Okay, this is my last case. What do you guys think? I can show you. So prostate, rectum, and then coming down into the anus.
Like a mass of the anal canal and the skin around the gluteal fold. Yes,
exactly. So all of this is kind of a really nice example of, you've got the dark muscle of the internal sphincter and the external sphincter, and then we've got this evil gray mass infiltrating through the sphincter into the intersphincteric space, and then onto the puborectalis there, and then also all the way down onto the skin. So what kind of anal tumor do you think this is?
Squamous cell?
Yes, good, yeah. Good. So that was the main point of what I wanted to show this case, was just to remind us that most anal tumors are squamous cell. So 85% of them are going to be squamous cell, with only 5% being adeno. So you don't use the rectal cancer template, and if you use instead this, I'll just pull up the SAR. So the Society of Abdominal Radiology has all these DFPs. The rectal cancer one is very active. If you scroll down to rectal and anal cancer, you can get the anal squamous template. And the important points here are that it's staged completely differently than rectal cancer. One point is that the T staging is based almost entirely on size. And you only get a T4 if you're invading another organ, but it does not include the sphincter, skin, rectal wall, or subcutaneous tissue. So only, for example, if it's invading the prostate or some other organ, then it's a T4. My lesion was greater than 5 centimeters, so it's a T3. You talk about lymph nodes. So if it's below the dentate line, they usually spread to the inguinal lymph nodes, and above they spread to like the mesorectal lymph nodes. And one important point is that a lot of these patients have HPV infection, which is what caused the squamous cell, but a proportion of them will also have HIV. And so there's a little bit of a different criteria for the inguinal lymph nodes in patients with HIV. So anyway, my case was basically just a large anal squamous cell that I did not see any pathologic lymph nodes, and was in a patient with HIV, and was invading the skin, but that does not make it a T4.
It was a 30-something-year-old female, almost 40-year-old female, with hemorrhage requiring transfusions from the vagina and cervix. And so this was the finding here. I think there's packing material in the vagina, and some of this is sort of hemorrhagic stuff. And then when you get to the cervix level, looks pretty normal there. And then you end up with masses of the uterus, some of them superficial, some of them intramural. One of them looks like it may be luminal. And so my differential here was, am I looking at cancer in a relatively young individual of the endometrium, or is it just leiomyomas? Leiomyomas can bleed rarely, pretty badly, especially if you have one that's torse. And I just looked up the path, and it's leiomyomas, so it was benign.
Wow, I wouldn't have liked those like irregular margins.
Yeah, I mean, I was nervous about this case, so I marked it for follow-up.
Wow, cool. I guess common things being common, but yeah.
All right, that's